Welcome to the next instalment in managing tendinopathy in the lower limb. So this session's looking at the clinical diagnosis of tendinopathy, and within this we're going to look at some of the risk factors around lower limb tendinopathy as well, to try and just get a bit more understanding. So it leads on from the etiology session that we've already run. Now, clinical diagnosis is largely made from our subjective history. It's the most important aspect of our clinical diagnosis. So that's no different from any other area of musculoskeletal physiotherapy. It's all about talking to the patient, having expert communication skills with the patient, and really understanding what's going on with the patient at all times. That's the best thing that we can really get to grips with. So the site of pain when it comes to tendon disorders is quite critical. Okay, so most people with something like gluteal tendinopathy would point to the greater trochanter area with the radiation of pain down the thigh. When it comes to the Achilles, we may have a much more sort of simplistic pinpoint sort of tenderness around the mid portion or the insertion, and the patient should either point to that zone or grip those zones and suggest that that's where their tendinopathy is. If we ask patients with something like patellar tendinopathy to identify the site of most tenderness, they should point to the inferior pole of the patella. So essentially with most tendinopathies, we know at this moment in time that the pain is rather localized and has nociceptive factors, certainly in the lower limb. Gluteal tendinopathy may spread and have some secondary sensitivities, and when it comes to the upper limb, we more frequently see centrally sensitized sort of states where the other limb may be involved and pain thresholds may reduce elsewhere. But the evidence for the lower limb is that that doesn't actually exist, and there's an argument going on with sort of our diagnostic criteria, but that's one for academics to worry about, I think, rather than us as clinicians. Now, when it comes to diagnosis, it's really critical that we comprehend simple axonesas. Okay, we're looking for activities that load the given structure, in this case the tendon, and those activities should increase symptoms as the load through that tissue starts to progress. And in particular with tendons, it seems to be really important to consider the speed of that loading. So something like walking is normally less provocative than running, and running may be less provocative than trying to do something like a triple jump or doing more aggressive hop testing. So we should see that as we ask the tendon to energy store and undergo a stretch shorten cycle, the sensation of discomfort can go up, and that discomfort may not just be during the activity, it may be prolonged and be the aftermath of that activity. So obviously if people have had previous treatment, we want to be looking at what happened and what that treatment was. And in my practice, I see a lot of second opinion, third and fourth and fifth opinions with tendons where people have already had lots of treatment. And it's always interesting to understand what they deemed the treatment was. And bear in mind that patients won't always remember what you've actually asked them to do or what you think is the key treatment. But understanding how they benefited or didn't benefit, because that's an important component that we need to potentially educate them about with why we're going to do something different this time around. And then the fourth aspect really in your subjective is to understand which risk factors may have actually led to this onset. And we need to consider a whole variety of intrinsic and extrinsic factors. Now, before we get to the actual factors, I also think it's important to consider the mechanism of onset, because this may tell us a little bit more about what specifically happened to cause this problem. So what you'll notice on this particular chart is that sudden onset, this blue component here, seems to account for around about a quarter of the population. And this is based on my epidemiology data from my PhD and is related to the Achilles. But it suggests that a group of people had a sudden onset of pain during an activity, and that was the initial trigger for their Achilles tendon disorders. Now, it's important, I think, that we tease this subpopulation out, because in my mind, the gradual insidious onset, the green here, okay, or the day after training, the red here, may well reflect a typical overload-induced tendinopathy. Whereas the blue group, this sort of quarter of the population, I think it actually equated to 28% of the group, may well have actually had collagen tearing, and it may be that this population do not respond in the same way. So one of the aspects of your subjective during your analysis is to write down, were they a sudden onset or a gradual sort of insidious onset? And if it was a sudden onset, identify as a possibility of a tear, and you then need to audit your notes as you go through your treatment over a course of a year to look at whether this group of the population respond in the same way as the others do. My experience at this moment in time, and we have some studies hopefully upcoming looking at this, they do not respond in the same way as other people do to loading. We are much more likely to flare them up, and they are more likely to go on to require more invasive procedures like surgery. So the other aspect then is to look at sort of the other trigger components. And in our epidemiology data, runners primarily identify overload as one of those key factors, that increased running seem to be the trigger for their disorder developing. And that makes sense if you go back to our etiology session that we previously ran, talking about the mechanism of change within tissue. And that is primarily based on this particular sort of graphic, where we have stress on the tissue on one side, wear, and we have repair on the other hand. And basically our tissue, whether we talk about bone or tendon, is maintaining homeostasis during normal activities. And if we increase the stress on the tissue, the wear on the tissue, we start to degrade tissue. But if we've got good reparative processes, that's no problem. The body is nice and robust and it will adapt and become more resilient. However, if there are factors that influence the repair rate, so genetics, adiposity, certain sort of other disorders going on like diabetes within the body, or hormonal changes linked to menopause in women, then we influence the reparative rates, the rate the body can sort of recover at. And we sometimes see the scales tilted to more wear occurring, and that starts to degrade the tendon, as we've previously discussed, and that degradation itself is what leads to structural changes, which is part and parcel of tendinopathy. Okay, it is my strong opinion that we cannot say we can get tendinopathic symptoms without structural changes. That is an absolute clinical rarity to find that patient. Okay, I'm sure they exist, but I would challenge the mechanism of imaging that's been done in most of those cases, because we have lots of data at the moment with MRI scans reported as clear, but UTC scans showing quite profound changes in the tendon. So I think there's problems sometimes going on there. So it's really about maintaining tissue homeostasis, okay? And we've talked about this a little bit, but inflammation is part of that process. This is low-grade inflammatory chemical messaging pathways that would normally stimulate cellular adaptations, okay? So risk factors sit into these two camps. They either increase the wear on the one hand or the repair on the other hand. And we need to consider how we can influence these factors. Many of these factors are non-modifiable, okay? We have two blue sort of factors here identified in the repair: increased BMI and diabetes. They're arguably modifiable factors, but it's very tricky for us to change those factors, and they're both linked with inflammatory chemical messaging molecules. But diabetes is also linked with a thing called advanced glycation end products, and they're thought at this moment in time to be non-modifiable, that once you've developed these glycated bonds between collagen molecules, we can't actually get rid of them. Okay, so we can change diabetes, but we can't change those. Importantly, clinically, I probably never changed the patient's BMI and never changed their diabetes status but we manage to get patients feeling better. So I do wonder if these are actually sometimes confounders for other factors that we can influence. And in a recent systematic review published by Robert Jan de Vos and reviewed in the Physio Network sort of review, sort of the muscle weakness was one of the modifiable factors that sort of sticks up and is maybe where we should be targeting some of our interventions. So during our objective examination, we need to exclude other possible diagnoses. And sometimes these other diagnoses can be quite profound. And I'm going to show you a list shortly that shows you all of the potential factors or disorders that may present as posterior heel pain, which could be confused with Achilles tendinopathy. And the list is pretty large. As part of our testing, I think we have to be looking at doing isolated and, importantly, measurable, quantifiable strength tests for the muscle that's involved. And this is based on both my clinical experience but also my research experience, where people can often have problems with weakness that can be hidden during more complex motor tasks like hopping. Whereas when you actually isolate the muscle, and you test it either using laboratory kits as we have behind us here, or using some simplistic clinical tests looking at isometric strength, then we can see huge deficits in the muscle and the tendon that's actually under testing. And those tests need to be progressive. We need to make them harder as the person recovers, but we also need to look at them initially to grade how severe this person is affected by their tendinopathy. And within all of the tendinopathies that we see in the lower limb, there are some specific sort of special name tests that we can utilize to identify whether the tendon is or isn't involved. Okay, and last, we should be looking at doing some form of imaging and palpating the tendon. Okay, palpation of the tendon, like we said, is not diagnostic in its own right and will be often symptomatic a long time after the tendon has recovered and the person is back to doing very good function. However, that pain on palpation and pinpoint sort of pointing to the pain are some of the most sensitive specific tests for tendinopathy. So they should form part of our clinical examination. When it comes to the Achilles as the example to sort of play this out, name tests are the London Hospital test and the painful arc sign of the Achilles tendon. We'll collect some short videos to show you those tests, which will be added as a resource afterwards. The London Hospital test is basically dorsiflexing the foot whilst palpating the tendon, and as you dorsiflex the foot, the symptoms will reduce normally. And the painful arc sign of the Achilles would normally involve palpating the swollen zone on the tendon, dorsiflexing the foot passively over the end of the bed, and looking at whether the lump moves within the tendon or stays still. If the lump moves, you normally determine that the change, the swelling, the thickness is inside the tendon, whereas if the lump stays still, you may deem that it is actually a peritonean disorder, the sheath is a problem. And then what we would move on to after these sort of specific tests is tests to look at the function of the muscle tendon unit. So we may stretch over a step, do double leg heel raisers, single heel raisers in both bent and straight knee positions, and then progressive loading. Now, many of these aspects form part of the Visa A scoring system. Okay, and if you want to read about some of these diagnostic tests, have a look at these two reviews. So we have a nice systematic review with meta-analysis from Mike Raymond here, and we have Anne-Marie Hutchinson's sort of testing study as well. They're very good, and they'll give you some figures for the sensitivities, specificities of a variety of tests. Now, if we think about the posterior heel and getting symptoms in that area, there's a whole spectrum of disorders that can present with symptoms in that region. This is a list. It is by no means full and complete, but it includes the more common of these pathologies that may present there. And The ones that we will tend to miss, and I find clinicians miss, are posterior ankle impingement, where you're getting pain that is felt often sort of behind the malleoli, around the Achilles tendon, and can be very confusing for patients. But the pain, instead of being related to tendon loading on your ags and eases, is more linked to going into a plantar flexed foot position. And in a plantar flexed foot position, the calcaneum and talus will actually migrate up, and the talus will impinge against the posterior malleoli. And that will cause changes in either the soft tissue or the bone, and may lead to formation of an ostrigonum, an exostosis of that region. So it's important we looked at forced plantarflexion tests. There is no load on the tendon. If a forced plantarflexion test is provocative, we normally start to consider posterior ankle impingement, particularly if the aggravating and easing factors were linking with that. And I've certainly in the last couple of months seen a few triathletes who have been diagnosed as Achilles tendinopathy disorders and managed as such when they've actually had posterior ankle impingement that's been influenced actually when they're swimming rather than running predominantly. Having an accessory soleus muscle is also one of these aspects that can mimic Achilles tendinopathy. So an accessory soleus muscle is where you have a very low insertion of the soleus, normally going nearly all the way down the tibia and then coming across onto the tendon. And it may produce swelling in and around the sort of fat pad, so Kager's triangle, just anterior to the Achilles tendon, and can sometimes present with symptoms that often people describe as compartment syndrome-like. So they have symptoms that come on during activity and ease afterwards. In my experience, those symptoms actually persist for a long period afterwards, and I'm not convinced it's really related to pressure within the compartment, but that's my personal experience. And you don't see many of these cases. I can count really probably 5, 6, maybe 7 people I've ever seen with it where it's been problematic. And the older treatment would have been to remove that section of the soleus muscle, surgical removal, and there's a few new options coming out, maybe looking at Botox injections and other aspects. One other important component not to miss in particularly active athletic individuals is stress fractures, particularly of the calcaneum. And we've had, again, a few patients recently who have bony tenderness of the calcaneum with some anomalies in the calcaneum that probably really represent having a stress fracture or some sort of reaction or bony change, and they need to be sort of looked at totally separately because their management will be very, very different from Achilles tendinopathy. And that is why we need to look at all these things. The management will differ for all of these conditions. Even when we come down to then having an Achilles tendinopathy, we can actually split it into a whole variety of potential groups. Okay, so we can have mid-portion versus insertional problems at the bottom. Mid-portion is the 2 to 6 centimeter zone above the insertion, whereas insertional problems are normally the superior aspect of the calcaneum and down. We may have plantaris-induced tendinopathy, which would be seen with more medial section pain and is often a little bit higher than is typical of the true mid-portions. And it may occur due to compression of the plantaris tendon against the Achilles tendon, particularly in extremes of dorsiflexion or plantarflexion. And Lorenzo Maschi's done some excellent work showing this occurring in cadaveric legs. And then we have a variety of different tears, so tears where the tendon is split sort of lengthways, a longitudinal tear, maybe a small tear across, or a tear of the fascia crura, which is a little bit of connective tissue lower down. And these all seem to occur in people who are a little bit younger, and the symptoms are normally sudden onset during activity. And as I indicated earlier, I think that these need to be teased out as separate entities in their own right and probably have different management. Equally, a group that have changes in the peritoneum and have a true inflammation of the peritoneum probably need to undergo different treatment options, okay? And my experience, again, is that these people have normally used some footwear that has externally compressed the Achilles tendon, causing the sheath to rub against the tendon. So the sheath sits around the tendon. As the tendon moves, literally they're getting this increased friction and they develop a peritoneum disorder as a consequence. Insertional tendinopathies, based on the current literature, do not respond as well to loading, are more likely to persist for longer and have poorer outcomes with rehabilitation. And one of the key sort of rehabilitation differences would be to not go into dorsiflexion in the early stages if the person has a high sin factor, severity, irritability. And within insertional tendinopathy, I would consider Haglund's deformity, so a bone change, a bursal change, a bursitis, or a tendon change as entities within insertional tendinopathy. And those entities may occur by themselves or in conjunction with the other bits. So you may see a bony change that has a bursal change with a tendon change as well, or combinations of. And there's still arguments about management for that, but that's for another time. Now, my take really is we strongly need to consider all of these within our analysis during our examination, because they probably need very different treatments, but we just don't know what those treatments need to be at this moment. And in the first instance, we need to come up with ways of identifying these groups to see if they all do as well with normal care. As I've already said, my experience is that they don't, but that's an anecdote, and we need research to actually drive what we do. Now, how we measure and quantify muscle strength can be done in a whole variety of ways. If you have access to a gym, we can try and use sort of 1 rep max testing, or 10 rep max testing, or whatever you want to do within a gym format to get a gauge of the person's muscle strength. But this is difficult to do sometimes on one leg. My preferred mechanism is using the physiometer, which is sort of some a Nintendo Wii with some external software from Aalborg University in Denmark, to test the isometric strength. That's the quick, easy clinical test. But the gold standard that we validated this testing against is actually to use the isokinetic dynamometer. But I totally appreciate that many of you won't have access to that within your clinics, and I certainly don't in mine. Equally, a lot of people will look at heel endurance testing, so heel rise endurance testing. The problem with doing this is you need to compare against normative data, if anything. If you compare against the other leg, when this has been looked at by Karen Silbernagel, there's no difference between the symptomatic leg and the non-symptomatic leg. And nobody as yet has done a study to show what the heel rise or heel endurance is for people with and without Achilles tendinopathy, to see if there's a difference. So whilst it's commonly used, it may not be sort of useful in the clinic, other than just giving a ballpark of where the person is at that moment in time. If you are going to use that type of testing, you could, and I would strongly suggest, you come up with a Blue Peter way of doing it, and that's UKism. Blue Peter's a TV program, and they often make things themselves. And this study at the top made this particular sort of method themselves. So this is an elastic band across the leg here, or across the heel, that's just attached to some bulldog clips to keep it straight. And what you can see is as the person lifts up, it should go perfectly straight. Now, this gives you a very good way of measuring when the person's done a proper rep. And if you use a metronome through your phone, you could actually ensure the person does a proper test. We can use more expensive research equipment here, as Karen Silbernagel's done, using this particular tool to measure heel rise. But it has quite an expense to purchasing one. So I think using the top method here, but on a decline board, as per this study, would give you the best way of actually measuring plantar flexor endurance within a clinical environment. And it's something that, if you're handy with woodwork, you can make yourself, a la Blue Peter. And you may want to also consider using some apps that are out there. So My Jump is one of those apps that's available on sort of iOS and Android, I think now, and it gives you a way of quantifying jump test in hops, but actually linked to sort of hard research tools. So this has been validated in the lab. So if you want to look at hops, this is one way of doing it and producing meaningful examinations to give an objective marker to the patient. So once we've got our diagnosis, we need to consider what type of tendon it is. Is it an energy storage tendon, Achilles, patella, arguably gluteal tendon, or is it more of a positional tendon, so potentially tib post, maybe arguably peronei, and again, GTPS sometimes will come under a positional, depending which camp we fall in with what the gluteal muscles do and don't do. We need to consider the stability of the symptoms, the sin factor for that particular person, because this will guide how we start our treatment. And within sort of our analysis, really consider, could there be a collagen tearing that occurred, i.e. sudden onset, which factors interlinked to trigger this condition off in the first place? Because in many instances, if it has come about because of overload, we were probably only going to need an educational intervention to bring about a good resolution for that person. But we will normally in the clinic add in some additional things to try and expedite that. But if overload is the trigger, education about that and a gradual return to activity is probably sufficient for the majority of people. Consider some differentials. So if we're thinking about the fat pad, when we're considering plantar fascia problems, it's often forgot about. People forget about having fat pad changes here, okay, atrophy of the fat pad, or forgetting about having neural irritation around sort of the different nerves down there, like Baxter's nerve. And we need to ensure that when we're talking about plantar fascia patients, we're talking about the same populations, not very different populations, diverse groups. The same is true of all of the tendons. When we get to gluteal tendons, are we really talking about the gluteal tendon and a potential for associated bursa, or are we talking about other aspects? Our patients with gluteal tendinopathy will normally be female patients, postmenopausal, because these hormone changes are part of the risk factors, as is increased adiposity with the BMI. So these systemic factors seem to influence the body's ability to repair the tendon with normal activities. So when it comes to subjective examination for GTPS, we've got to consider sleep disturbance as one of the entities that go on. These patients will often struggle to lie on that side at night, and that is often indicative of having pain around the sort of gluteal tendons themselves, as well as then getting load-induced pain in progressive activities, so maybe just standing versus walking uphill or going upstairs. And we also need to consider the possibility of hip or lumbar referring into that region, and they should be excluded within our examination protocols. The best testing that we have when it comes to gluteal tendon is from Alison Grimaldi's work. This is key work, and there's some lovely pain propagation tests that either involve stretching the muscle or stretching the muscle and then contracting it at the same time to squash it against the bony sort of contours nearby, i.e. your greater trochanter. And that combination of testing allows us to determine if the gluteal tendons seem to be the site of where the person's symptoms are originating. These are our typical populations that we see gluteal tendinopathy affecting, and often it will be related to these changes in adduction occurring at the hip. So this measurement here, where that lady's hip is adducted in that position. And it's important we examine our patients doing the activities that are provocative for them to see if we can have a biomechanical issue and potentially a biomechanical resolution to their problem by changing their hip adduction angles. So always look at your patients doing the activity that they're complaining of, because that will give you a good insight if there are any flaws with doing it. Now, Alison Grimaldi's battery of tests has been published in the British Journal of Sports Medicine. I would suggest that you all have a look at this sort of robust battery, and what we're looking for is sort of 4 or 5 of these tests to be positive out of the total available tests. Single leg stance for 30 seconds on the one leg whilst maintaining neutral. I would ensure that they maintain a neutral as well, so there's not a Trendelenburg positive test. So the PSISs, ASISs and pelvic crest, iliac crest stay level, and there's not a drop when the person stands on one leg, which is commonly what you would observe in many of these patients. And then the other tests, the fader and the fader with an R, is basically stressing the tendons by stretching them, and then adding in the resistance test, which is the R. And there's also the Faber test, which uses a flexion with abduction instead of the adduction in the fader. And again, this test causes compression of some of the tendon sections against the greater trochanter. The adduction test is very much like Ober's, okay, the old ITB stretch test, and we do the same movement with resistance built in to activate the muscle whilst it's in a squashed position. These tests are very, very similar to our empty can, full can tests that we have used in the past for sort of shoulder rotator cuff related disorders when we've been looking at supraspinatus as well. And palpation comes up as then one of the most sensitive specific tests we can do. This is the tests that were published in the British Journal of Sports Med in 2014 by Alison Grimaldi and the rest of the group, looking at sensitivity, specificity, positive predictive values and negative predictive values. Please have a pause and have a look at that, and also have a look up the paper to get some more information. I would add in some additional tests for our patients. I would add in looking at inner range hip abduction strength, particularly with a slight extension, because if we're doing it with a slight flexion, we're actually activating TFL and some of the hip flexors instead of gluteal medius and minimus, and that's really what we want to be looking at. And often during this test, if you take them up into full inner range activity, i.e. as far as the hip will move, you've taken them to full abduction. You then ask the patient to hold it there, and often what you'd observe is a drop, a lag. It will drop down because they're unable to maintain that position, or it will induce their pain, or it will induce a sensation of cramp. And it helps us to do this test to show the patient that they are weak in these muscles if we're looking at a strength-based intervention later on. And we can quantify this by using a handheld dynamometer if we want to as well. We should also add in probably 2 other tests really, where we're looking at not just medial and lateral rotation of the hip joint in a flexed hip position, as you can see on the left, but we're also doing those same tests when the hip is in an extended position, as you see on the right. And the reason that we would do that sort of combination of testing is to look at several of the rotator muscles of the hip, because they change their function when the hip is flexed versus extended. And the common one that we all know about is piriformis. Piriformis in a hip flexed position would actually be a medial rotator, and our stretch is put in an externally rotated position. When piriformis is in a hip extended position, it reverses its action. Okay, it is movement that it's triggering is actually reversed, and we normally use the pro-knee fallout test, so actually medially rotating to stretch it, because it's now become an external rotator. So glute med and min also alter their activity in those same positions, and this work comes from Delp and a variety of other people who've identified that the middle and posterior fibers of both glute med and min swap their action from flexed to extended positions, and they go from being a medial rotator to a lateral rotator. Now, this tells us we should be looking at lateral rotation strength when we're in a hip extended position, and ensuring that we try and test patients through both these different activities and positions really to do so. So that's one of the aspects we need to consider now with it. We also need to to build into our subjective examinations with the patient about a variety of psychosocial elements that influence tendinopathy. So particularly fear avoidant and catastrophizing behaviors, because these allow the patients to avoid doing the activities because they're very worried that they may go on to snap their tendon or cause further flare-ups. And much of this is seated in their experience of what's gone on so far. So we need to try and change these beliefs and show to the patient that their tendon is robust and can cope with large stressors as it does do in normal day-to-day activity. And there's work that's undergoing at the moment using the Tampa scale of kinesthesiophobia. So have a look at that scale, and I would encourage you to use that scale within your tendon, within patients you see with tendinopathy. There is some work from Adrian Mallow's systematic review on that subject and his PhD as well, and Mel Plinsinger as well. So do have a little read of those papers on this, because they are useful. And when patients are telling us a variety of aspects or asking us a variety of questions, we should be challenging them. So often they're very worried that they should just perpetuate what they're doing and keep going and ignore the pain. And that's no good. We need to get them to listen to it, because that pain is due to a reaction in the tissue. We need to get them to offload in order to settle it. But often they're also very fearful about what's going on and the need for further invasive procedures or imaging to be done. And that isn't always essential unless they're failing to respond to appropriate care. So let's consider risk factors that may have led to the onset of this disorder, that the person has localized pain that is there on palpation, and that we have excluded other pathologies that may mimic this particular tendinopathy. And we've completed a variety of isolated tests to identify what the muscle tendon unit can do at this moment in time to act as a target for our rehabilitation. But within all of this, we've looked at the person, and we've ensured that we've challenged those beliefs that the person has about what's wrong and their understanding of the disorder, so they come on board and do the interventions that we prescribe to them. Thanks very much for listening, and I look forward to the next instalment. Cheers.